Hello and welcome to Dementia UK Summer School presentation on palliative and end-of-life dementia care. My name's Rachel Guest and I work as a hospice Admiral Nurse up in West Yorkshire. I'm going to run through a presentation that looks at recognising dementia as a life-limiting illness, our understanding of palliative and end-of-life care for people with dementia, thinking about those important early conversations that we can have and the decision making towards the end of life for somebody. Just for reference for the presentation, I think it's really important to think about the term dementia that I'll be using throughout the presentation, and that when I'm referring to dementia, I'm actually referring to different types of dementia that people will be living with. We are facing one of the biggest global health and social care challenges. And some of the statistic data the Alzheimer's Research UK Dementia Hub have produced shows really how the projection of the diagnosis rates of people living with dementia, but in particular that in England and Wales, the number of people living with dementia who are going to need palliative care is almost going to quadruple by 2040. Which makes it even more important that we think about services and we think about how we can approach and our understanding around providing palliative and end-of-life care for people living with dementia. There are national guidance as well that help us put those things into perspective about what it is for dementia care to look like. And we've got the dementia strategy, we've got an end-of-life care strategy and NICE guidelines. We have here the NHS, the World Pathway for Dementia. And as you can see, right at the end of that is the dying well. However, I think in order for people to have a good end of life care, it's actually important that we think about those conversations we have when people are living well with the diagnosis. So, what do you understand by the words palliative care, end of life care, last days of life? Think about how you view or use these terms. What about if you hear these terms? What comes to your mind? Or what do you perceive the status of that person might be if you hear the word they're under palliative care or at their end of life or they're in their last days of life? The World Health Organization defines palliative care as an approach that improves the quality of life for patients and their families facing the problems that are associated with living with a life-limiting condition. So as you can see, it's about having layers and there's phases of care that people will go through. So the overarching terminology is that palliative care approach. It's introducing an approach to care and treatments that allow people to live with that condition as well as that they can be, and managing things for them and maximising that quality of their life. We then move into a stage where we think that people are entering that end of their life. And it's really starting to think about how we are going to provide further ongoing medical treatments that are appropriate for them at that stage. And we're really looking at maybe the people that are in those sort of shorter months, weeks to life. And then people enter the terminal care phase and the last days of life. So when thinking about that model and the layers of care, what does this mean for people that are living with dementia? Well, the guidance from NICE is clear that people living with dementia should be offered a flexible palliative care based on needs that considers how unpredictable that progression can be. So we need to consider and recognise that dementia is a life-limiting condition. Sadly, we cannot cure that condition for people. And although we want people to live well and support people to have really good quality of life, we need to also recognise that there does come a time when things do change for that person. And although that does give a difficult trajectory, the one that we don't have a crystal ball necessarily about, because sometimes people might be also living with other illnesses and there might be other comorbidities that somebody may have, such as heart failure or respiratory disease or a cancer. And therefore people sometimes are dying from dementia, but they also might be dying with dementia. And as dementia progresses and the disease changes, we start to see those symptoms of frailty come in as well and affect the person. It's thinking about where would that preferred place of care and the preferred place of death be for somebody living with dementia, and how do we have these conversations with them and their loved ones? It's about understanding that people living with dementia and people caring for those living with dementia certainly have uncertainty around disease progression, around that trajectory. And therefore, it is really important that we do focus on that person's care needs. There are real key challenges, though, in identifying that point at which somebody living with dementia starts to die with dementia. I think sometimes there is a range of terms that we describe the care of people living with a life-limiting condition, and this does lead to confusion for patients and professionals. So that ambiguity with definitions can certainly impact on care planning and delivery. And therefore, when we're sort of talking about a palliative approach, the European Association of Palliative Care recommended that adopting a palliative approach in dementia care entails actually a creation of a new model of palliative care that is designed around and incorporates the unique features and needs of people with dementia. It's understanding their care goals and the shift and the change that they may have as the disease changes. It's really understanding how advanced care planning can play a key component in that, and I'll come on to talk about that later. It's about thinking around those optimal treatments of symptoms and how actually that may change over the trajectory. What might be optimal at one point for somebody may start to change as their condition deteriorates, as well as living with other conditions. What does focusing on somebody's care look like, and what does comfort look like for somebody? And making sure that there are no unmet needs for that person, whether that be physical, psychological, or physical, psychological, social. It's really keeping that person at the centre of all that we do. It's ensuring that we're involving family care involvement. People living with dementia do not come in silo. They come with families who love and care for them. They might also be formal carers as well if they're living in a care home. And therefore, we have to think about that triadic relationship that we have in involving everybody involved with that person, including themselves, and things are really clearly communicated and that there is a shared approach to some of that decision making. And by doing that, the idea is that hopefully we start to think about recognition of that dying phase for that person, and therefore starting to avoid unnecessary and overburdensome treatments. So as dementia progresses, we can think about the suggested prioritising of care and the goals and shifting, because the style of care as dementia progresses cannot be prognosis based. People will not go from the mild stages to severe stages in an easy trajectory and one that we can easily define. And therefore, what good palliative dementia care looks like is less about prognosis and more about focusing on the needs that that person has. It's based on having a sensible and appropriate level of care that's provided according to that person's needs. So as somebody starts to show a decline and starts to show things changing for them, whether that's dying from dementia or dying with dementia, it's looking about what our priorities are to focus on, and it can lead us to guide some of those supportive conversations. So we start off talking to people about what matters most to you now in living life and having that high quality of life, prolonging life, maintaining your function and keeping things living as well as you can. And then as things start to change and suddenly we're in a state where that person has increased care needs and complexities, then what is our focus? What is it that we want to maximise that person's comfort? What does that look like? When we think about the palliative and end-of-life care for people living with dementia, and particularly thinking about moving, if you think about those layers of care, moving into that end-of-life care, care planning, I think it's important that we recognise and think about living with advanced stages of dementia. And I refer to this sometimes when people are living in the advanced stages, that they're in that final phase of life. This can be a protracted period for several years, and again, that's why it can be a really difficult trajectory, but it is identified by a profound level of dependence on people. The disease trajectory is likely to be characterised by symptoms of increasing frailty. There may be physical symptoms changing, such as mobility, becoming incontinent. There might be changes with that person's eating and drinking and developing swallowing problems. There can also be a combination of the behavioural and cognitive disturbances that really contributes to the need for that accurate assessment of that person's needs, not only just physical, but also the emotional, psychological and spiritual symptoms. There's a challenge, however, that a person with later stage dementia may also show more rapid decline associated with such events as a fall or continued infections, and can have symptoms that suggest they are close to the end of their life. However, they may then plateau and continue to live with these symptoms for many months. And therefore, it can make it really difficult for the person and their family to plan for the end of life. And therefore, getting back to earlier, thinking about that person being in the final phase of their life and having those conversations. And we're thinking about moving towards the end of life care, where we think that that person may be in the last years of their life. And although it is difficult to predict, if we're focusing, as I said earlier, on the person's care needs rather than how long they have left to live, rather than focusing on prognosis, that when the person is starting to show some of these changes and a decline and thinking about their care needs, then we can start to think about how we support their care. What are we focusing? What are the priorities? What matters most now? What do we need to be thinking about? What are the wishes and the preferences of this person and their loved ones? And as we start to think about that, then we can put all that scaffolding and buffering around that person. So whether it's a rapid deterioration with a shorter prognosis versus more a slower decline over a protracted period, the care needs for that person are being met, and that's the priority. So recognising end of life, what does that look like? How do we recognise the end of life for somebody living with dementia? Well, that's a real huge challenge, and one of the problems is that practitioners can fail to recognise the signs of end of life early. As we've mentioned, there can be a rapid decline and there is a difficult trajectory. But as we've talked about, it is less about that prognosis and more about a focus on the person's care needs. And so that we can use certain prognostic indicators, and these enable us to recognise changes within a person. And when we've sort of recognised that people may be showing a significantly reduced appetite with a loss of interest in food and drink, or starting to refuse it completely, there's elements of weight loss. There might be swallowing difficulties, for example, they might be coughing, or they might have difficulties clearing their throat after eating or drinking, or taking a longer time to eat and drink. They might be developing frequent infections. There will be significantly reduced mobility. They may be experiencing frequent falls due to those changes within mobility. There might be reduced communication and becoming more withdrawn. They might be sleeping considerably less, more, and they might have difficulties controlling their bladder and bowel and experiencing incontinence. And I think if a person is starting to show a number of these signs, then we can start to think about putting plans in place, not only one to meet those care needs, but to recognise where they're at living with their condition and living with their diagnosis. And there are, as I say, there are certain prognostic indicators. We have the gold standards framework, the supportive and palliative care indicator tool, but also we can use what we refer to as the surprise question. And all that is do we say, would we be surprised if this person was to die in the next 12 months? And I think sometimes just by recognising that that person is showing change, it doesn't have to be certain, but it certainly shows the indicating the value of intuition and that clinical expertise. What we need to be then thinking about and looking at that person's condition and how things are for them and becoming increasingly frail is sometimes that intensive medical care for that person. If they were to become less well, to carry on getting lots of infections, for example, or acute medical conditions, we do know that hospitalisations for people living with dementia can rapidly cause sometimes physical deconditioning. So we can see a worsening in their status. It can cause them distress, and they've got a higher risk of developing a delirium, and certainly have prolonged recovery time and have a heavy impact on the quality of life. And therefore, it's really important that when we see these changes with somebody living with dementia and seeing how their care needs are changing, talking about the goals of care and discussing the risks, benefits and burdens of what care and treatments look like for that person becomes really, really important. And this leads on to us then thinking about that decision making that we have towards the end of life for somebody. And actually, as I said right at the beginning, when you look back at that dementia care pathway, what we want to do is have effective care plans in place where somebody is able to express their wishes and preferences around a time when they are approaching the end of their life and what they want the things to be focused on for them. So care planning for end of life help those involved in somebody's care to provide that effective support and person-centred care and prevent us having to make decisions in a reactive way, thinking about, do we send them to hospital? Is this appropriate? Would they want this? Wouldn't they want that? So actually, what we need to be doing is taking a proactive approach and thinking about what those advanced care plans look like for people. And ideally, conversations should take place at the earliest opportunity while the person who is living with dementia has the capacity to make their wishes known and clearly understood. Because sadly, as we know, as the disease changes, people start to lose some of that capacity. But how do we have the conversations and priorities that matter most to people? What do these conversations look like? Sometimes we can have them with the person and we can capture them. And sometimes that person may not have that mental capacity. We may have to have it with loved ones and people who are those proxy decision makers. Well, I think if we're trying to think about what that person's care, how we're going to support their end of life care, one, we need to find out what that person's understanding of the condition is and where that person might be with the illness, where they are at with their illness. What are their worries and fears about becoming less well, about what are their worries and fears for their loved ones? And what are the goals and priorities if we sort of talk about time becoming shorter? Again, we don't have to give a prognosis. We just know that things are changing, and we wouldn't be surprised if that person was to rapidly deteriorate or to start to show changes that might mean that they may struggle to respond to treatments for acute conditions such as infections. And therefore, what is a person willing to go through or not go through at that time? And if we start to address some of these conversations, then we can start to think about what that person would want their care and treatments to look like. Supporting a person living with dementia at the end of their life and their families requires a team approach. And often there are going to be many people involved in that person's care towards the end of life. And therefore, it's really important that we have good communication and information sharing, so it helps us ensure that that person receives the care that they need. And where a person with dementia lacks or has impaired capacity to make decisions for themselves, then we have to be guided by the principle of the Mental Capacity Acts, and doctors and clinicians must ensure that we are considering what options, whether that's including non-treatment or pharmacological treatments, what's going to be the least restrictive of that for that person based on their future wishes. If they have any written down, we need to be taking into account any evidence that patient has expressed those previous wishes, such as the advanced care plan. We need to work with those who are close to the patient and the members of a healthcare team to explore views about the patient's preferences, feelings, beliefs and values, and whether they consider the proposed course of action would be of overall benefit to the patient. If that person has made an attorney for their health and well-being, then we need to make sure that we are in communication with that individual, because they will be that decision maker for that person on their behalf. So a health and welfare attorney allows somebody to make decisions on that patient's behalf about their health and welfare when there comes a point that that person isn't able to make those decisions for themselves. When we're looking at decision making around end of life care, when we're focusing on a time when somebody has lots of care needs, really what keeps that person pain free? And when we look at pain, it sometimes is the whole pain. And so therefore, what is it that makes that person feel calm and relaxed? What is it that brings them emotional comfort? What is it that brings that person physical comfort? What does the environment need to look like that makes that person feel safe and comfortable? And these are all really important ways of symptom management, comfort care planning for people in the advanced stages of dementia and thinking about them entering the end of life care. What we do know is that people with dementia are at risk of receiving poor care because they're not able to say what they want in a way that we can maybe understand. However, people living with dementia still continue to communicate to us, but this might be in a different way. They might show us in the changes in their body language, in their verbal communication, by their facial expressions. They will attempt to communicate an unmet need for us, whether that's that they're in pain, they're not comfortable, they don't like the environment's overstimulating, or they're bored, or they feel they're not emotionally being comforted and they've got some psychological distress. And so therefore it's really important that we get to know that person and we get to know what it is that they should, the changes that that person will display that can make us know that they're trying to communicate something to us. This is how they are when they're feeling comfortable, when they're feeling contented and happy, or rested, or not in pain. But this might be something that they will show us when they're trying to communicate an unmet need. And that's really important in providing good end-of-life care for people living with dementia. It's about understanding who the person is living with this condition. What is it that they can tell us that we need to know to make sure that we are managing those symptoms as best that we can, whether that's in a pharmacological way or a non-pharmacological way. So just to summarise, if palliative and end-of-life care does not take into account the unique circumstances and needs of people with dementia, then we're likely to fail them. If we don't start talking and communicating about things changing, about the disease progressing, and thinking about what care needs to look like for somebody at that point, then we're not going to know what we need to be doing for that person. We need to use the knowledge of dementia or understanding of it as a disease, but also we need to know who the person is that's living with this disease. We need to go beyond a task-focused care approach and actually prioritising really important planning and communication with the person and also their family. And I'll just end with a quote from Dame Cicely Saunders, who founded the hospice movement, who says, "You matter because you are you, and you matter to the last moment of your life. And we will do all we can, not only to help you die peacefully, but to live until you die." And I think that's the challenge for us when we're supporting people living with dementia and their families, is to think about what can we do for them to not only help them have a good end of life care, but to help them have that quality of life as well. Thank you.